Acute Care Nurse Assistant, Module 10, Cardiovascular Care. Content 1, Basic Terminology. Terminology, Clinical Setting Application. Content 2, Basic Cardiovascular Anatomy and Physiology. The heart, a hollow organ not much larger than a fist. It lies in the center of the chest, behind the breastbone, in front of the spine, and above the diaphragm. It pumps blood to the lungs and to the body. The normal heart beats 60 to 100 times per minute. Each time it beats, it ejects about 2 ounces of blood and can pump out up to 37 quarts each minute during exercise. The heart has its own electrical regulating system called a pacemaker. It's located in the right atrium. This electrical impulse is transmitted to all the heart muscle by a specialized conduction system. This electrical impulse causes a contraction of the heart muscle that causes it to pump the blood out to the body. The heart muscle has 3 layers. Number 1, the pericardium, the outer layer, a thin sac that covers the heart. Number 2, the myocardium, the middle layer, the thick muscular portion of the heart. And number 3, the endocardium, the inner layer, the membrane lining the inner surfaces of the heart. Heart chambers. 2 upper right chambers called atria. Right atrium and left atrium. 2 lower chambers called ventricles, right ventricle and left ventricle. Right atrium. Blood returns back to the heart from the body through the superior and inferior vena cava into the right atrium. This is oxygen-depleted blood which must be replenished with oxygen. It pumps this dark bluish-red blood to the lungs, where blood rids itself of waste gas, such as carbon dioxide, and picks up a supply of oxygen, which turns it a bright red again. The right ventricle. The blood flows into the right ventricle from the right atrium, where it is pumped out through the pulmonary artery to the lungs, where blood is reoxygenated and carbon dioxide is removed. Left atrium. Blood flows from the lungs through the pulmonary vein into the left atrium. This is bright red, oxygen-enriched blood. The left ventricle. The blood flows very passively into the left ventricle. The blood in the left ventricle is oxygen-enriched blood and is pumped out of the aorta to all body areas. Capillaries, small vessels which bring nutrients and oxygen through the blood to the cells and tissues. Capillaries also take the waste gas, carbon dioxide, from the cells and tissues to the veins. This process occurs in the lungs, the rest of the body, and the heart muscle itself. The heart valves. The tricuspid valve is between the right atria and right ventricle. The pulmonic valve, between the right ventricle and the pulmonary artery. The mitral valve, between the left atrium and the left ventricle. And the aortic valve, between the left ventricle and the aorta. Content 3. Procedure for monitoring in the acute care patient. Accurate vital sign measurement. Normal values for pulse. Different sites for pulse, such as the carotid, apical, radial, brachial, and pedal. Changes in pulse strength and amplitude. Heart rhythm, regular versus irregular. Automatic blood pressure machine, i.e. Dynamap. Reset between patients. Some machines will only inflate the cuff 10 to 20 millimeters Hg above the previous systolic pressure. Proper technique in obtaining orthostatic blood pressure, lying, sitting, or standing. Doppler for determining pulses and blood pressure. Removal and replacement of telemetry unit and monitoring leads when showering. Assess pain, the 5th vital sign. Content 4. Common disorders of the cardiovascular system. Myocardial infarction, or heart attack. Ischemia and angina. Definition: myocardial infarction, a heart muscle damage due to a clot in the coronary artery. Ischemia or angina. Lack of oxygen to the heart muscle due to the narrowing of the coronary artery. Signs and symptoms: chest pain and pressure, arm discomfort, indigestion, jaw pain, shortness of breath, sweating, and nausea. Care measures: report changes in bowel pattern, activity intolerance, signs and symptoms. Congestive heart failure. Definition: poor pumping of the left ventricle causing backup of fluid in the lungs. Signs and symptoms: shortness of breath, edema of extremities, tachycardia, fatigue, decrease in activity tolerance, decrease in urine output. Care measures: fluid restriction, report change in breathing, accurate input and output, daily weight, and activity level. Peripheral vascular disease. Definition: narrowing clots in the legs, veins, or arteries. Signs and symptoms: extremity change in temperature, hot to cold, tingling, change in color, paleness, redness, decreased movement, pain, change in or lack of pulse, loss of sensation, and swelling. Shock. Definition: decreased delivery of oxygen and nutrients to body cells and organs. Signs and symptoms: weak and rapid pulse, tachycardia, drop in blood pressure, decreased urine output, pale and cool skin, decreasing level of consciousness. Care measures: report to a licensed nurse, assist in obtaining a crash cart. Absence of heartbeat. Care measures: call emergency code, start CPR, assist with obtaining crash cart. Content 5. The nurse assistant's role in caring for patients after invasive cardiac procedures. Observation of arterial puncture sites for bleeding or swelling, such as a hematoma. Maintain activity restriction guidelines, flat in bed, straight extremity. Observation of dressings over puncture sites for drainage. Placement of sandbag. Recognizing and reporting changes in extremity pulses. Vital signs as ordered. Usually Q 15 minutes by 1 hour, Q 30 minutes by 1 to 2 hours, or Q 1 hour by 4. The special precautions in the care of a cardiac patient. The care measures for CHF and PVD. Showering. Remind the patient to rock in place to avoid blood pooling in extremities and fainting. Careful observation of patient when telemetry removed. Telemetry unit. Careful placement of telemetry unit in gown pocket. Avoid getting wet. Electrodes secure. Good contact with skin. Important of continual use of oxygen for patients with O2 order. Anticoagulant therapy, such as heparin, Coumadin, TPA, Redovase. Special precautions: avoid use of razor blade, observe for bleeding and bruising, and avoid the use of aspirin. The importance of accurate input and output and weight measurements for the cardiac patient. Review input and output. Review measurement of weight and stress, important of accuracy. Input and output and weight gain or loss can indicate change in fluid balance or change in cardiac function. Medications and fluids are frequently adjusted based on these measurements. Content 8. The role of the nursing assistant with the patient who is experiencing a potential life-threatening situation, such as a cardiac arrest. Possible life-threatening signs and symptoms include change in respirations, especially shortness of breath, pain in the chest, arm, or jaw, change in activity tolerance, altered level of consciousness, bleeding, changes in vital signs, pallor. Review steps of basic life support, CPR. Content 9. Risk factors for coronary artery disease. Smoking, obesity, high blood pressure, elevated cholesterol, glucose intolerance, lack of exercise, emotional stress, family history, sex and age of patient, and race. Reinforce patient teaching plan regarding risk factor and lifestyle changes. Module 10. Measuring pulse. Radial, the most commonly measured pulse. It is measured at the radial artery in the wrist. Feel for the radial artery with the patient's arm positioned along the side of the body, palm downward. Curl 2 or 3 of your fingers around the wrist on the thumb side and palpate gently. This site for measuring pulse is convenient and accurate. Occasionally, if a patient has had many arterial blood gases, ABGs, drawn, the radial pulse is difficult to feel, and the ulnar pulse and brachial pulse must be used. Never feel for the pulse with your own thumb. It has a pulse of its own, and you may be counting your own pulse. Brachial, located near the center of the antecubital space, toward the little finger side of the arm, the inner aspect. Have the patient rest the arm palm upward, and use 2 or 3 fingers to locate the pulse. This pulse is commonly used to measure blood pressure by placing the stethoscope diaphragm over the site. Pedal pulse, dorsalis pedis. The pulse is felt on top of the foot while it is in plantar flexed, if possible. This pulse is easily obliterated, pushing so hard you close off the artery, so feel gently. This pulse is used to check peripheral circulation when the femoral artery has been used for an invasive test, such as a heart catheterization, or cath, or arteriogram of the extremities. It is also the pulse that is used to check circulation when a patient is in a cast, or has had orthopedic surgery, such as a joint replacement. Apical pulse. This pulse is used when the radial pulse is irregular or is difficult to palpate. You must use the auscultation method, listening with the stethoscope, when taking an apical pulse. The apical rate represents the actual beating of the heart. When auscultating the apical rate, the lub-dub heard represents 1 cardiac cycle or heartbeat. The apical pulse is counted for 1 full minute. Most hospitals require that all patients on telemetry in the hospital have an apical pulse taken with vital signs. Apical pulses are checked for 1 full minute whenever you are uncertain of the accuracy of the radial pulse, or it is irregular, difficult to obtain, or too fast to count. Whenever a pulse deficit exists or is suspected. Before the licensed nurse administers drugs that alter the heart rate or rhythm on any patient on telemetry. In children whose rapid rates may be difficult to count at the radial or brachial artery, and any child under 12 months of age. Apical radial deficit. This occurs when a difference exists between the radial and apical pulse rates. This usually means that some of the contractions of the heart are so weak that sufficient blood cannot be sent to the arteries to expand them. When this happens, no radial pulse is felt. The pulse deficit is the difference between the apical and radial pulse rates. The nurse may wish to assist in taking an apical radial pulse. 2 persons are needed to take this pulse. Nurse 1 measures the pulse apically using a stethoscope, while at the same time Nurse 2 takes the pulse by palpating the radial artery. The pulses are measured for 1 full minute using a single watch that is placed in a convenient location where both nurses can see it. Module 10. Normal ranges and age-related vital signs. This graph is a compilation of normal ranges found in textbooks. Your facility may have other values to use as guidelines. Also, in individual cases, the nurse may request a report for vital signs of different values. Be sure to follow your facility policy. Measuring blood pressure. Guidelines for taking blood pressure. Make sure the blood pressure cuff is the right size. The width of the cuff should be able to wrap at least halfway around the upper arm. Normal sizes of cuffs. Approximately 5 inches wide for the normal adult. Narrower cuffs, about 3 inches wide, are for the infant, child, or adult with a thin arm. Larger cuffs, about 8 to 9 inches wide, are for obese patients or for taking blood pressure on the thigh. Do not use an extremity that has an intravenous infusion, is diseased or injured, is paralyzed, is severely swollen, contains a renal dialysis shunt or fistula, is on the side where a mastectomy has been performed. Procedure. Position the patient's arm so that it is level with the heart. The palm should be up. Squeeze the cuff to expel any remaining air. Close the valve on the bulb. Find the brachial artery at the inner aspect of the elbow. Place the arrow on the cuff over the brachial artery. Wrap the cuff around the upper arm at least 1 inch above the elbow. It should be even and snug. Palpate radial artery and inflate the cuff until pulse can no longer be felt. Note that value. Deflate the cuff. Place the stethoscope earpieces in your ears. Position the diaphragm over the brachial artery. Inflate the cuff 30 mm Hg beyond the point at which you felt the last pulse. Deflate the cuff at an even rate of 2 to 4 mm per second. Note the point on the scale where you hear the first sound. This is the systolic reading. Note the point where the sound disappears for the diastolic reading. Inaccurate blood pressure readings. Causes of inaccurate blood pressure readings include the use of the wrong size cuff, an improperly wrapped cuff, incorrect positioning of the arm. It should be in line with the heart. Not using the same arm for all readings. Not having the gauge at eye level. Deflating the cuff too fast or too slowly. Mistaking an auscultatory gap as the diastolic pressure, or not going high enough to hear correct systolic pressure. And improper use of automatic blood pressure machines. Electrode reapplication. Telemetry transmitter box. Batteries, lead wires, electrodes, alcohol swabs, safety razor with shave cream or lubricant. Criteria. Correctly reapplies electrodes and telemetry unit. Gather equipment. Make sure transmitter number matches the monitor number assigned to the patient. Snap or clip lead wires onto electrodes. When snap type is used, make sure they are snapped on before applying to patient to prevent pressing against chest wall and causing discomfort. If necessary, shave excess hair on sites needed for application of electrodes, then cleanse sites with alcohol swabs or acetone per your facility policy. Gently rubbing the skin surface with a gauze pad to remove dead skin cells helps the electrodes adhere to the skin. Remove backing from self-adhesive electrode and apply to prepared skin site. Follow your facility policy for placement of electrodes, as there are different systems used for monitoring, and the leads must be placed in the correct positions. Make sure lead wires are securely inserted into transmitter box and, if it has an on-off switch, make sure that it is turned on. Place the transmitter box into the pouch that is usually supplied on the hospital gowns of the telemetry patients. If there are no pouches in your facility gowns, have the patient place the box in a pocket of the robe or sleeper when they are walking. Care should be taken not to drop the box or allow it to get wet. Electrodes should be changed every day and the sites moved slightly to prevent skin breakdown. If the patient is complaining of itching or burning under the electrode, hypoallergenic electrodes are available at most facilities. Notify the RN of any skin irritation. Document date, time, and preparation of the skin, where you applied the electrodes, and obtain a rhythm strip for documenting the heart rhythm. Module 10, Case Studies. Mrs. Hansen is one of your 11 patients on a busy telemetry unit. She is 67 years old and has a history of severe hypertension, cardiac arrhythmias, and diabetes. She is hospitalized for stabilization of her blood sugar levels and is due to be discharged soon. It is now 10:30 a.m. You check on Mrs. Hansen before you start a bed bath down the hall. She is sitting up reading a magazine, but has a frown on her face. She seems anxious, but she says she feels this way often and is anxious to go home. You step closer and notice that she is shaky and says she has a headache. What would you do? The licensed nurse does a finger stick blood glucose and finds Mrs. Hansen's blood sugar is 45. The licensed nurse has you go get a small glass of orange juice and some crackers and cheese. Later, after you have gotten her the snack, she says she is all right, but as you begin to leave the room, she starts to rub her left arm and shoulder. She says she's just been sitting up too long, but as you step closer, you notice she's sweating and pale. What would you do? After you call for help and get a set of vitals, you find that Mrs. Hansen's blood pressure is 210/112, and her heart rate is very irregular. You decide that Mrs. Hansen needs help right away, and go to get the licensed nurse since no one answered the call light. As you go out to report your findings to the licensed nurse, you notice the patient has slumped over in her chair. What is your first action? Mrs. Hansen is one of your 11 patients on a busy telemetry unit. She is 67 years old and has a history of severe hypertension, cardiac arrhythmias, and diabetes. She is hospitalized for stabilization of her blood sugar levels and is due to be discharged soon. It is now 10:30 a.m. You check on Mrs. Hansen before you start a bed bath down the hall. She is sitting up reading a magazine, but has a frown on her face. She seems anxious, but she says she feels this way often and is anxious to go home. You step closer and notice that she is shaky and says she has a headache. What would you do? The acute care nursing assistant should know from the study of the cardiac and diabetic patient that many diabetic patients have cardiovascular disease, and complications of both diseases are seen often on a telemetry unit. Changes in blood pressure, heart rhythm, and blood sugar can cause signs of shakiness, diaphoresis, and headache. It is not the acute care nursing assistant's responsibility to connect a diagnosis with the symptoms, but they should recognize these symptoms are new and reflect a change for this patient. Even though the patient says this happens often at home, any change in a patient's condition should be reported to the licensed nurse. The acute care nurse assistant should report the signs and symptoms mentioned above to the licensed nurse right away. The information should be relayed to the licensed nurse before beginning the bed bath that needed to be given to the patient down the hall. The licensed nurse does a finger stick blood glucose and finds Mrs. Hansen's blood sugar is 45. The licensed nurse has you go get a small glass of orange juice and some crackers and cheese. Later, after you have gotten her the snack, she says she is all right, but as you begin to leave the room, she starts to rub her left arm and shoulder. She says she's just been sitting up too long, but as you step closer, you notice she's sweating and pale. What would you do? There are new symptoms and are similar to symptoms a patient might have when having cardiac problems. You realize the nurse should know about these new symptoms right away, but with these serious symptoms, you should not leave the patient. Depending on the layout of the nursing unit, you may just call for the nurse with a spoken message or put on the call light. While you are waiting, you could take the patient's vital signs and try to relieve anxiety by speaking in calm tones. After you call for help and get a set of vitals, you find that Mrs. Hansen's blood pressure is 210/112, and her heart rate is very irregular. You decide that Mrs. Hansen needs help right away, and go to get the licensed nurse since no one answered the call light. As you go out to report your findings to the licensed nurse, you notice the patient has slumped over in her chair. What is your first action? You cannot leave the patient now that you have seen her slump over in the chair, and you return to assist the patient and push the emergency button or appropriate call signal for your facility to get help immediately. You begin the ABC steps of CPR. Determine unresponsiveness and maintain an open airway. If the patient is breathing, give support to prevent falling until help arrives. If the patient was not breathing, you would need to follow guidelines of CPR and the limitations of your role as outlined by your facility. Module 10. Caring for patients with peripheral vascular disease. 1. Elevate the feet when the patient will be sitting in a chair for a long time. When the feet are not elevated, make sure that the patient's feet are flat on the floor. 2. Discourage smoking. It interferes with circulation. 3. Avoid using the knee gauge of the bed. 4. Avoid using heating pads or hot water bottles. The patient may not feel temperature that is too hot. 5. Maintain body warmth. Make sure the patient has warm clothes, including socks that fit well. Provide blankets for the bed. 6. Prevent injury to the feet. Instruct the patient to wear shoes when out of the bed. Check to see that the shoes are in good repair and that they fit well. Avoid pressure to the legs and feet from any source. Inspect the feet carefully when you bathe the patient or if the patient complains of any discomfort in the feet. Promptly report any signs of inflammation, injury, or circulatory problems, such as broken skin, color change, redness, whiteness, or cyanosis, heat or coldness, cracking between toes, corns or calluses, swelling, pain, loss of function, and drainage. Bathe the feet regularly. Dry thoroughly and gently between the toes. Use a moistening lotion on the feet and legs if the skin is dry. Do not cut the toenails of patients who have peripheral vascular disease. Thank you for your attention.